Hello, how are you? I'm Dr. Sebastian. Now again, we're going to continue with the seminars, but now with a new methodology. Because of the strike, now we're going to have all the seminars in version online with videos. And when the strike is over, we're going to find out how we continue with the program. The class of today is going to be about labor conduction and monitorization. So the objectives of this class, the thing that I want you to learn, is how to perform a physical examination to a day-to-day obstetric patient, how to do a correct vaginal examination, in which features we have to focus when we do a vaginal examination, also how to fill a partograph, how to interpret the partograph, and how to prepare oxytocin infusion in order to augmentate the labor when it's indicated. With all of that information, we will be able to understand how to diagnose a non-resurmal fetal status and a cephalopelvic disproportion. Both diagnoses are very common in normal pregnancies, and it's very important for a midwife, for a general doctor, a clinical officer, to know how to manage that problem and also how to diagnose them. To start this presentation, I choose these images to show that the delivery process, the labor, is very common in all around the world. All the animals have to deliver, and they do it in a natural stage, in a natural situation. So most of the deliveries in humans also doesn't have pathologies. If the mother is young and she have a controlled pregnancy and everything is normal, there is no pathologies. But there are some things that can happen that we can prevent. For example, the dogs, when they give birth, they have like 9, 12 little dogs, and a little part of them can die during the delivery. For example, in a normal delivery of a dog, 2 dogs can die, 2 little dogs, newborn dogs can die. The difference with the human being is human deliveries are in hospitals, are in a controlled setting, by doctors, by professionals, nurses, midwives. That is the reason that why we can monitorize the delivery, monitorize the baby and the mother, take care of the mother well-being in order to prevent and detect all the problems that can happen during labor. Here I present you the systematical approach pyramid. It's very important to have in our heads that a patient is like a book. So every book have different chapters, and we need to read the book from the first chapter to the last chapter. We cannot read the last chapter before the first one. That is the reason why we need to be ordered while we are taking information from a patient. So the next step, the first step to take information from a patient is the clinical story. It's all the things that we ask to the patient. For example, if the mother have a controlled pregnancy, if she take all the antenatal care visits, how she was feeling with the baby, all the important things. And if you keep your order, you will never forget anything. The second thing is the physical examination. It's like the second chapter. So after talking with the mother all the important things that you know how to do it better than me because I don't know Swahili, you have to do the physical examination. That is the second step. And this step, it have subdivisions that we're going to talk about it. And after that, if we have enough information, we can make a diagnosis. But there are some situations in which after the clinical history and the physical examination, we don't have enough information. For example, the mother doesn't have antenatal care visits, she doesn't have a recent ultrasound, or she have some little complaint of reduced fetal movement, or she have, for example, high BPs in the physical examination. So something is not good, something is going wrong, so we need to go further, explore further with other tests. For example, to ask a laboratory to preeclampsia severe features, or for example, to ask for an ultrasound to check where is the placenta, or anything like that. So the message here is that we have to save that tests only for the mother that need that test, not to ask all the time for exams if the mother doesn't need them, okay? Because the resources in the hospital are limited. So we need to be responsible about the things that we ask to our patients. So now we have a clinical case. I want to every one of you now, Tanya, Benedict, Jane, Onyancha, Silvia, please, let's feel in this situation. It's Friday at 4 p.m. and you are working in labor ward. Yesterday night you were on call, so now you are very tired. All the week you have been studying a lot for this IHS, so you are almost falling asleep. Okay, ni me choca sana. And a mother comes. A primigravida with 40 weeks gestation by date, safe and trustworthy, had recently come. She was complaining because of 8 hours of low abdominal pain and increased uterine contractions. She had 5 antenatal care visits that show a normal pregnancy, normal blood pressures, everything normal, and a recent ultrasound the last week that shows everything okay, good placentation, baby encephalic. So everything seems to be a normal pregnancy. So after this story, what we usually do in the labor ward? As I said to you, the systematical approach pyramid said to us that we have to start with the physical examination. So in the physical examination, what are the important things that we have to find? The most important here is to be ordered. So we have to start with the general exam. In the general exam, we have the general conditions, if there are fair general conditions, bad general conditions, the vitals, of course, if there is jaundice, pallor, all that. After the general examination, we need to start with the per abdomen examination. That is the exam that we do on the abdomen, measuring the fetal heart rate, the fundal height, the Leopold maneuvers, that Tanya, you know it very good. Search for tenderness, that is a very important part that not all the people remember, but it's very important to search for tenderness because tenderness is not a normal thing in labor. And the measurement of uterine contractions to look out for the frequency, the duration, and the intensity of the uterine contractions. That is also a thing that nobody does in the ward because of lack of time or because they are very tired, like this situation. After the per-abdominal examination, you have to perform the vaginal examination. This is very important because the vaginal examination is not have some risk. So we need to avoid the vaginal examination in special cases. For example, in PV bleeding, or for example, in preterm gestations. So the external genitalia inspection we have to do to all the women, but the vaginal inspection, the vaginal examination, only in non-PV bleeding women and in term gestation. If the mother is bleeding per vaginal, or if the mother is preterm gestation, we cannot do a vaginal examination and we need to do a speculum examination. Why? Because if the mother is bleeding and we perform a vaginal examination, we can make the mother bleed more because of a placenta previa, for example. And if the mother is preterm and we do a vaginal examination, we can induce labor because of the infections that we can provoke with our finger. So in our clinical case, after the examination, we find out that everything is normal. Okay, so the vitals, the general examination, the per-abdominal examination shows a term baby in correct position. The vaginal examination shows 4 centimeters of dilatation, 100% effacement, without blood, without show, anything like that. So what we do after all this? In this situation, we have a normal pregnancy, a normal labor. What do? Well, we saw in the pyramid that we need to do after the clinical history and then the physical examination, we have to do a diagnosis. So which is our diagnosis in this situation? To do the diagnosis, to make our own diagnosis, we need to be ordered also. So the things that we have to put in our diagnosis in order is first, the parity. So that is important, and that information you get in the clinical history about the obstetric history. So the parity, in this case, the mother is primigravida. The gestation, In this case, the mother is term, and you can put the weeks, for example, 40 weeks, and you can put gestation by date, you can put by scan, or by physical examination. Then, if the mother is in labor or not, so you have to put active phase of labor, latent phase of labor, or if it's not in labor, you don't have to put anything more. And other conditions in the situation that the mother maybe have, for example, seropositive or rhesus negative, or for example, she have a chorioamnionitis, or any other conditions, preeclampsia, any other condition, any other diagnosis that it's important to put, you have to put after the labor. So if after that clinical story and all of this is normal, we don't need to call the consultant, we don't need to translate the patient if we are in a rural area very far away. We only have to continue with the monitorization and continue with the labor. So there is a question. In this situation, which is the best examination to estimate when the mother will give birth? In this situation of a mother in labor, that is a normal labor, which is the best examination that we can use to estimate when the mother will give birth? Please, I invite you to put in pause the video and think about it, and after that, you can have the answer. Very good. I think all of you were right. The correct answer is B, vaginal examination. And why the vaginal examination is the best examination? Well, you will know it in a few slides more. So this image, this picture is from a person called John Yue. John Yue is the bishop of Nairobi. He's a very intelligent man. He's the most important person in the church in Nairobi, in the Catholic Church. And maybe you will be asking yourself why I put this photo. And the reason is because he's going to help us to remember his score, the bishop score. So this bishop is saying to us, use my score if you want to see EDD. Why is he saying that to us? To see EDD, if you look at it in the correct sense, is a 2, a C, a E, a D, and a D. So the two C's are from cervix consistency and cervix position. The E is from effacement. The D is from dilatation, and the other D is from descent. Those are the 5 important features that we need to look out when we are doing our vaginal examination. So now I will describe one by one all these features. The first 2 features that are the 2 C's is cervix consistency and cervix position. The cervix consistency is when labor progresses. Consistency change from firm to soft. So at the beginning, the cervix is firm. Also, when the mother is not in labor, the cervix is firm. But during the hours in labor, all the uterine dynamic, the contractions, make the head to punch all the time the cervix, and the cervix turns soft. The position of the cervix is also something that changes in labor. So when labor progresses, the cervix position changes from posterior to anterior. Each one of these have a score that we will use and we will talk soon. The effacement is a very important part of the vaginal examination and is the same than the length of the cervix. It can be measured in centimeters when you talk about length, or in percentage when you talk about effacement. In Chile, we talk about percentage, but here in Kenya, most of the people use the length in centimeters. It's important to know both of them because there are some people in other hospitals that will use effacement and you will not understand. So that's why I'm explaining both of them. So to understand this easily, it's important to know that the cervix length, the normal cervix length, is 4 centimeters. So when there is 0% effacement, it means that the cervix is 4 centimeters. If there is 50% effacement, so it means the half, it means that the length is 2 centimeters. Okay, and when we talk about 100% effacement, we talk about like the cervix length is less than 1 centimeter. All of you are going to be able to measure that with your finger in the palpation. Okay. The dilatation is the most important feature, in my opinion, of the vaginal examination, because we can estimate how far is a normal pregnancy. We can estimate the dilatation because we palpate with our finger, and if we feel, for example, 3 centimeters, we know that to reach 10 is 7 centimeters more. And if the dilatation in a normal labor is approximately 1 centimeter per hour, we can estimate the time of delivery of the mother. And we can diagnose, for example, any problem that we have during the delivery in order to estimate the time. For example, if the mother has a cephalopelvic disproportion diagnosis, it means that the head of the baby is bigger than the pelvis of the mother, so the labor is going to be prolonged and it's going to be slow. So we can diagnose that taking the measurement of the dilatation. That will be the same dilatation in a time or without descent in a time. So that is the reason why it's very important to know how to perform and understand the dilatation. And how we do that? With our own fingers. Here I show you this because it's very important for you to understand that when you measure the dilatation in the cervix, you cannot open the cervix with your fingers. So if you look here at the video, if this is the cervix and it's round, if you put your fingers and you do like this, you will open more the cervix. But that is not the correct measurement. The correct measurement is only to put your fingers in the lower part of the cervix, like here, yes? Not here. And with that, you only measure without opening more the cervix, and you measure. Okay? After that, your fingers will show you how many centimeters are. If you put two fingers inside the cervix without opening the fingers inside the cervix, it means that are 2 centimeters. If you can open it with a little of aperture, it's 4 centimeters. If you can open it a little more, it's 6. And of course, you can go to 10 centimeters. Of course, this can be different person to person because all of us have different fingers and different hands. So it depends on your fingers. And you, as a clinical officer, need to calibrate your hand, calibrate your finger, comparing your VE with the VEs of an expert. So if you are if you are on call with Felixta, try to do VE for the patient that Felixta do VE, and you compare and you talk with her, so you can go calibrating your fingers. Now, the next question. This is a very challenging question. I hope you can figure it out. What happened first, dilatation or effacement? I invite you to pause the video and think a little about this, and you will have the answer in the next seconds. Well, the correct answer here is that depends on parity. Why depends on parity? Why this depends in the parity? Because a very simple reason. The primigravida have the cervix long and never have been passed through the cervix a baby. So the os is puntiform. When the labor is progressing, the cervix will first efface. The effacement will start completely, and after the effacement is completely done, the cervix is going to start the process of dilatation. So in the primigravida comes first the effacement and then the dilatation. In the multipara, the os of the cervix is a little open because there are babies that have come past through the cervix time ago. That is the reason why when the labor starts, in the same time start the process of effacement and the process of dilatation. In the same time. Also, the delivery in average is more fast, is rapidly. So there are some situations, for example, if the mother are in 3 centimeters or 2 centimeters, so she's not in active phase of labor, but if she's a multiparian, you need to be aware, because if the mother maybe live very far away, you cannot discharge her, you cannot send to the house, because maybe she can deliver in the taxi, she can deliver out the house. So it's very important to know that the multiparian labor is faster, and also You cannot previse if the mother is going to be very fast or not. Okay, so to continue with the presentation, the distance is the fifth feature important that we need to check in our vaginal examination. The distance is the grade of progression of the fetal head through the pelvis. And we have two ways of measurement, the per-abdomen way and the vaginal examination way. The per-abdomen way, we use the rule of the fifth. We're going to talk about that sooner. But when we're talking of engagement, when the head of the baby is engaged, when we have 2/5 of the baby inside the pelvis. In the vaginal examination, we use the method of the spines. So we palpate the spines in the vaginal examination, and we compare the presenting part of the baby with the height of the spines. If it's up, we give negative number. If it's down, we give positive number. I'm going to explain in another slide. And we talk about engagement in spines when the baby is -2 or -1 centimeters. So, spines. Here in this photo, we can see a person performing a vaginal examination, touching with this finger the spine. That is a bony prominence that you can touch if you go deeply and posterior during the vaginal examination, and lateral, as a little lateral, you will touch the spine. While you touch the spine with the other finger, you have to touch the presenting part of the baby, and you have to compare if the baby is upper, that presenting part, or if the baby is downwards. If the baby is down, you give positive numbers, as I said to you previously, and if it's up, you give negative numbers. When the fetal head is at the same level as the ischial spine, you call station 0. Okay? And the per-abdomen way, as I said to you, is like a Leopold maneuver. You have to touch the baby, palpate and distinguish the fetal head, and try to figure out how much of the fetal head you can palpate above the level of the symphysis. If you can palpate the complete fetal head, it means that the distance is 5/5. But if you can palpate only, for example, 2/5 of the fetal head, it means that the baby is 2/5, and that means engagement. It's the same with all the other stations. So now, without all this information of all the 5 features that we need to check when we do a vaginal examination, how we put all this together? The bishop of Nairobi presents us the bishop score. That is a way in which we can put all this together and assess the cervical conditions in a very integrative way. So now that you understand the VE, use my score. That is what the bishop is saying to us. So the bishop score is a tool that we use mostly to assess how are the cervical conditions before performing an induction. But also it's very useful when we are evaluating a cervix, because we don't forget any of all the characteristics that we need to look out. Okay? When the score is 6 or more, we're talking about a favorable cervical conditions. And if it's below 6, it's unfavorable. These are all the measurements. So from firm to soft, it's only 2 points, because the cervix consistency and the cervix position are not as important as the effacement, dilatation, and descent. So coming back to our clinical case, which is our bishop score here? With all these things that we have, which is our bishop score? This one. So we have here the table. That is the same table that we need to perform with pencil in the file of the patient when we are admitting the patient. And in this table we put, for the category of consistency, we have 2 points. So we put here 2. In cervix position, 0 point, because it's posterior. Effacement, 3 points, because it's 80% effacement, or less than 1 centimeter of length. In the dilation category, that is, we have 2 points, because it's 4 centimeters. And in this end, we have -2. That is engaged, but is not well descent. So that gives us a point of 1. In total is 8. That means good and favorable cervical conditions. So now, in this situation that we have the diagnosis of a primigravida, a term in active phase of labor without any other condition, what we have to do? Like a normal pregnancy, the thing that we have to do is to admit the patient because she is in active phase of labor, and also to start filling the partograph and monitorization. That is a thing that in this hospital, in Mbagathi Hospital, anyone does because of time. Because there's no time, there's a lot of things to do, and anyone does. But why we need to fill the partograph? What are the benefits of the partograph? The partograph is a very important and useful tool. It's recommended by the World Health Organization. It's ordered and easy to fill. Most of the people think it's difficult, but it's very easy, really easy. In only one paper, you have all the information of the labor at a glance. It promotes continuous monitorization. It remembers you to check the fetal heart rate. It remembers you to check the blood pressure. And also have a unification of understandings. Because if you're on shift and you're entering your shift and there was someone that was working all the night with a patient, you will know when the VE was done, how far she was, and all that things. And it's much more easy to understand all the things that happen with your patient. Also, it's good because you have a registration of everything and guides you when to make an intervention. Because what happened? When you don't make a partograph, most of the people also they write in the file all the things that they discover and everything, but they are not able to understand when to make an intervention, when the mother is doing a prolonged labor, when the mother have a non-resumed fetal status. Why? Because there is a lot of patients, there's a lot of work to do, and maybe one patient you don't figure out, you are not focused, and you can forget that the mother is in a prolonged labor, for example. So in the partograph, as you see in only one page, and you see the progress of labor, and also the page have a line, an alert line and an action line, it guides you for what to do. So here I present you the partograph. This is an image of the partograph. And how do we fill this paper? It's a very big paper with a lot of different things. How do we fill this? It's very complex. But I'm going to show you that it's not as difficult as you think. So here we have the partograph. The partograph have 5 parts, but there are 3 principal parts. The other things are very easy. Okay? The first is the mother information, that you fill all the things, the ID number, the age, the parity, the gestation, all that things. And you fill only one time. The other easy thing is the medication. You put all the medication that you give in the time that you give, and all the intervention. For example, if you do rupture of membranes, you also have to put it. And the important 3 things that you must fill, and it's important to don't forget to fill, is the fetal well-being, the labor progress, and the maternal well-being. Each one of these parts have different sub-parts that I'm going to present you in the next slides. So, when do you start filling the partograph? You start filling it in active phase of labor. It means when the dilatation is 4 centimeters or more. Put the first dilatation with any X along the line of the alert and write the time when the VE was done. Fill in all the rest of the features needed. So we're going to see this one by one, so I'm not going to read, but we're going to see one by one the fetal well-being, the labor progress, and the maternal well-being. So the fetal well-being, first, is there are a lot of different things that we need to check. The most important, I think, is the fetal heart rate. We need to measure the fetal heart rate every 30 minutes and record in the chart. If the fetal heart rate in any of these measurements is above 160, it means that it's tachycardia. And if it's less than 110, it means that it's bradycardia. Both of them are ominous signs, and you need to ask for help to a doctor, to the midwife, to check why this is like this. And also, in the fetal well-being, in every vaginal examination, you have to feel in this part of the chart the amniotic fluid and the molding. The characteristics of the liquor, you have to put an I if the membrane is intact, it means the membrane is not broken, a C if the membrane is ruptured with clear fluid, an M if there is meconium stained fluid, or a B if there is blood stained fluid. And the molding is how the bones of the head of the baby are separated or not. So if there are separated bones, you put a 0. If there are bones just touching each other, that means 1 cross. Overlapping bones, but you can reduce when you palpate, 2 crosses, and severely overlapping bones, that is non-reductible, 3 crosses. The second part is the labor progress. This part is very important because we need to know if the mother is doing well with the velocity of labor, the velocity of dilatation, or not. If she is not doing well with the velocity, it means that maybe it's a cephalopelvic disproportion. And to diagnose that, we need to have the partograph feel. So I'm going to teach you now how to feel that part of the partograph. Uterine contractions, you have to measure every 30 minutes. To measure the uterine contractions, we need to be 10 minutes beside the patient with the hand in the uterine fundus, and for that we need a lot of patience. We need patience because in 10 minutes is a lot of time and we have a lot of work, and maybe it's going to be difficult, maybe it's going to be boring, but it's a time that you can take to sit down beside the patient, talk with the patient. Also, you can make an interview, maybe you can ask her how is she feeling, psychologically speaking, and all of that. It's very important always. And in order to know how is the uterine contractions, you need to check 3 things. First, the frequency of the contractions, that the normal is between 3 and 5 every 10 minutes. After that, you have to check the duration, that the normal is between 35 seconds and 45 seconds each contraction. If it's less than 35, it means that it's not enough to make a normal delivery, and maybe the delivery is going to be slow, the labor. And if it's above 45, it's a lot of contraction, and that can have problem for the baby. I'm going to talk about that soon. And the third important thing that you need to check is the intensity. That is a subjective perception about how strength is the uterine contraction. The important thing here is not to check about how is intensity, but to check about if the uterine allows the complete relaxation between contractions. Because if there is no complete relaxation of the uterus between contractions, it can have a severe consequence to the fetus, like prolonged hypoxia, and that can be very risky. And how do we feel these things in the partograph? With this, we put here in the highest of the bars the frequency. For example, here is 4 every 10 minutes. Here is 5 every 10 minutes. Okay, and the color of each square means the duration of each contraction. So if it's black, it's more than 40 seconds. If it's with lines, it's between 20 and 40, and if it's spotted, it's less than 20. The other important thing about the labor progress after the uterine contractions is the dilatation and the descents, that are very important features. The dilatation we mark with an X, and the descents we mark with a O. The descents is from here, from the fifth, to the 0, because we mark it in the rules of fifth. That means that we perform a per abdomen descents. And the dilatations we mark from 0 to 10. Okay? So here, for example, we have a dilatation at 12:45, a dilatation of 4. And then in the next vaginal examination that was at 2:45, we have a dilatation of 5. Okay, so from 4 to 5. That means that the mother is going well. And the descent of the head is also going well, because was 3 of 5 at 12:45, and then was 1 of 5 at 14:45. If this progression is not going well, you will be in a station. When you reach this line, that is the action line, you need to do something. To perform a CS, to call a doctor. There are a lot of things that you can do, but the important thing is that you need to monitorize this. If we don't write in the partogram these things, we will never realize that we are under a problem. After that, we need to check also the maternal well-being. That is to check the vitals to the mother, the pulse every 30 minutes, the blood pressure every 4 hours, the temperature every 2 hours, the urinalysis, and the urine output. This is a very subjective way, because not all of you do this in all the pregnancies. But the important here is that in a normal SBD, we have to do it like this. But if the mother have other condition, for example, preeclampsia, the blood pressure, maybe we have to take it every 2 hours or every 1 hour. If the mother have a chorioamnionitis, we have to take the temperature more frequently. And also to make examinations about the tenderness in the abdomen, or a lot of different things. So this is only in the situation of a normal, simple vaginal delivery and in a normal patient. So now I put you this situation. We're in Mbagathi Hospital, that the normal simple vaginal deliveries in a day is like 40. And we have only 2 health personnel, 2 clinical officers, and 1 midwife in the afternoon or in the night. So what do we do? Because the World Health Organization recommends us to do all the things that I say to you, to fill the partograph, to take all the vitals and all of that. But the reality here in Mbagathi is not that. We don't have the time, and we also don't have the strength to do all of that and to make that monitorization so frequently. So what do? Welcome to reality. With 40 deliveries a day, and we have only 1 SONI case and a few human resources, we need to select our patients. We need to select the patients that need more strictly monitorization. For example, which patient do we have to be more near and monitorize in a deeper way? The patient that have meconium stain fluid, the patient that have decreased fetal movement perceptions or prolonged labor, the mothers that are in second stage, because that stage have more risk than the first stage, and other symptoms or risk factors. For example, a mother that is with PV bleeding, or have fever, or have the diagnosis of preeclampsia. All of that things have more risk than a normal pregnancy, so we need to fill the partograph and make a good monitorization. For all the other women that there is no more things, and you don't have time to do all the monitorization, of course, it's not bad if you don't do it, because the time is not enough to do all that work. So after talking all of this about the physical examination and the partograph, which are the common diagnoses that we need to know and that can happen during an SBD? The first one that I want to talk about a little with you is the non-resurgent fetal status. Okay? The key diagnosis to diagnose this pathology is any sign that can suggest fetal hypoxia. It means meconium stain liquor, reduced fetal movements, or bradycardia. Any one of these in itself, in their own, can be a sign of non-resurgent fetal status. And the treatment for this, we have the immediate treatment and the definitive treatment. The immediate treatment is to perform intrauterine resuscitations maneuvers. And which one are these? To give oxygen to the mother, to put the mother in a correct position. That means in a lateral decubit position, because the uterus can compress the cava vein, and that diminish the preload of the heart. So if you put the mother in the left position, the uterus stop compressing the cava vein, and the preload increase. So the the cardiac output increase, and also the perfusion for the placenta and for the baby increase. After that, very important that you measure is to give fluids to the mother. So you have to give, according to the consultants and the doctors here in Mbagathi, you have to give 1 liter of normal saline or ringer lactate to the mother. But if the mother have preeclampsia or any condition that cannot support overload of volume, you have to give only 500 ml. Also, after give the intrauterine resuscitation, and while you are giving that, you have to think about the cause. Which is the cause of this non-resurgement? So the cause, you can think about it and try to find out, performing a complete exam, again, to the mother. So you have to do a BE, you have to check for uterine abdominal tenderness, because the diagnosis can be, for example, a cord prolapse. So in the BE, you will check it. Or, for example, it can be a rupture placenta. So you will check it, the tenderness and the intensive uterine contractions. All of that things that can orientate you to diagnose a rupture placenta. So it's very important to make, again, the BE and also to think about the cause of the non-resurgent fetal status. You cannot be waiting and treating this without knowing the cause. And also, of course, to communicate the medical officer for evaluation and for an eventual emergency CS, and to continue doing a strictly monitorization of the fetus. In my country, we call to this diagnosis the acute fetal suffering, because the fetal is with lack of oxygen. And one of the most common cause of the lack of oxygen to the fetus is because the placenta is not with the correct supply of blood. And why is this? Because here, in the uterus, we have the uterine artery that you can see here. And if we go more near, here we have the placenta. This is the placenta. And this layer is all the muscle layer of the uterus, all the muscles. These are the uterine artery that have arteries that cross through the muscles to go to the placenta here, to cross through the muscle to go to the placenta. When the muscle is very contracted during a contraction, these arteries cannot pass volume, cannot pass blood through the arteries because the uterine is very contracted. And that is a very wise mechanism, because after the delivery, the uterus must contract a lot to prevent the hemorrhage, because the placenta detached goes away here, the placenta, and this part of the uterus starts bleeding. So if the muscles here contract, the bleeding stops. So that was one of the common things. The second common thing that can happen during an SVD is the cephalopelvic disproportion. The cephalopelvic disproportion, as I said to you recently, is when the fetal head is bigger than the pelvis. Maybe the fetal head is not too big, but the pelvis is too little, or it happens the opposite. For example, the fetal head is very big in a macrosomy, and the pelvis is normal. So this diagnosis is very relative, but to diagnose this, you need to rule out another things. So what do you have to do? The key diagnosis for this is a poor progress in the descent despite inadequate uterine contractions and despite artificial rupture of membranes, and the mother ambulating and performing exercise, like squats, as Sister Tati said to you in the visit last week. The mother have to be with all the conditions to have a normal delivery. So the membranes must be ruptured, the contractions, the uterine contractions must be normal. That means 4 in 10 minutes or 5 in 10 minutes with a duration of 35 seconds to 45 seconds. And if the contractions are not optimum, we need to augmentate with oxytocin. If the membranes are not ruptured, we need to rupture the membranes. And after of that, we evaluate in 1 hour. If in 1 hour doesn't happen anything, or if we are trespassing the action line, we need to diagnose cephalopelvic disproportion. And the definitive treatment for that is to make a continuous fetal monitorization, because this has more risk of non-resurgent fetal status, and also to perform an emergency CS. So one of these things that we have to do to diagnose is to augmentate the mother with oxytocin in the case of the uterine contractions are not good. So how do we do that? The oxytocin infusion we need to prepare with 5 ampoules in 500 ml of normal saline. That means that we have a 0.1 international unit every 100 ml. So if we give this in a velocity of 10 drops per minute, it means that we are giving 50 milliunits per minute of oxytocin. And that is the starting dose for an augmentation. So we need to start with 10 drops per minute. Don't forget that, 10 drops per minute in 5 ampoules in 500 ml. And the maximum dose is 60 drops per minute. We can go titrating the oxytocin every 30 minutes, 1 hour, depending on how is the patient. And of course, we need to take care of the adverse reaction. One of the adverse reactions are hypotension to the mother, but that is not important because it's a transient and mild hypotension. But the most important adverse reaction is the very important increase of the uterine contractions. And we can go to the other side. Now we can start like hypoxia to the fetus because of the hypertony of the uterus. So every time that we give oxytocin, we need to make a monitorization of the fetal heart rate, and also we need to make a monitorization of the uterine dynamic. Because the important thing that I didn't say to you in the past slide is that one of the important principles of the intrauterine resuscitation, in addition of the position, in addition of the oxygen and the fluids, is to stop oxytocin. If the mother is on oxytocin, we have to stop oxytocin. Why? Because the oxytocin is a risk factor for hypoxia to the fetus. So now we finish. I hope you like this presentation. The little golden potatoes, the most important things of this presentation are the following. 1. The history and the physical exam are the essential part of the doctor's work. We cannot do it incompletely. It doesn't matter if we are tired, if we are on call, because it's to read the book, we need to read it completely to understand the scenario. The second point is to remember the bishop, to remember the thing that the bishop is saying to us, the bishop of Nairobi, to see EDD, so to remember the 5 features in the evaluation of a vaginal examination. You cannot perform a vaginal examination and only check the dilatation. You have to check all the things and read all the things in the partograph. The third point is the partograph is very useful and recommended to detect cephalopelvic disproportion and to detect non-reassurement fetal status and other pathologies during labor. But if there is no time, you have to select the risky patients, because the reality in Mbagathi Hospital is not the reality of all the hospitals. And of course, you need to select the risk patients, you have to categorize, and you need to focus yourself in all the patients that have more risk of having a problem. And the last point is the oxytocin is an overdose drug that can be harmful. You have to use it wisely and in the correct dosages. I hope this presentation you like. This is a better methodology because you can look it in the velocity that you want. You can pause the video, go back if you don't understand. Any doubt that you have, you can call me to this phone. This is my Kenyan number. And if you want to send WhatsApp, you can send to this. That is the WhatsApp number. And also my email, any of these 2 emails, I can answer to you any doubt. And also if you need to ask me more material, more information, I have information in English for you to read about all that topics. And I will send you by WhatsApp a survey to see if you like this methodology, and with a little questions about if you have internet on your house and other different things, and also to evaluate the first 7 classes of the course that were done in a pressential modality without internet. I need to check if I'm doing good classes or not. I encourage you to answer the survey because it's very important for me to make better classes. This is for you, for our patients, so we need to work together. See you soon. Have a nice day. See you guys.